So why don't we start? I'm Andy Nierenberg from Mass General Hospital, and I'm delighted that you're still here. Again, we're going to talk about new perspectives on ADHD and mood dysregulation. As many of you know, the name of our organization is APSARD with an R. The R is the related disorders, and I'm one of the related disorders people. So my expertise is actually in mood disorders, mostly bipolar disorder and depression. One thing is that, as you all know, mood can be described as either dimensional, categorical, diagnostic, and then we frequently use this word comorbid. I would dare guess that virtually nobody in the audience knows where the word comorbid came from. Does anybody know? Does anybody know who coined it? So the person who coined the word comorbid was Alvin Feinstein from Yale. He made up a lot of words, but that was the word that actually stuck. And what's interesting about the word comorbid is that when Alvin Feinstein first coined it, he really meant two disorders that had nothing to do with each other, right? So that you would have heart disease and you would have renal failure that wasn't caused by it, or you had cancer and hypertension. And in some ways, we really misuse that term because there's one brain, we think we have one brain, and that you could have a lot of things that are dysregulated in that brain that gets manifested in multiple ways. So it's not really comorbidity, it's more of an association than anything else. So with that in mind, I'd like to ask Tony to come up and start to give us an overview of what really is the issue. And as you hear these presentations, I urge you to think about spheres of dysregulation and multiple ways that dysregulations can happen that then manifest themselves clinically more than just a comorbid type of association.
So yes, I'm kicking this off so that you can really enjoy the next few speakers. Very, very humbled and grateful to have this opportunity. These are my disclosures. And let me just say that when you look at most diagrams of how the brains of people with ADHD work, and we think of this is a somewhat frontal-centric view, but you'll notice that the ability to guide cognition, inhibit behavior, and handle emotions, they're all living side by side and interacting with all these subcortical structures. So, it stands to reason that if you can't inhibit your emotions, you might have problems not only with thinking things through, but also handling all kinds of affective issues. So what I'm going to try and do is cover a little bit about the prevalence of emotional dysregulation in ADHD patients, talk about conceptual and measurement issues and how they're challenging in helping us try to think through how we look at I'm going to call it ED. Now, ED, it's a little bit dicey, right? ED, erectile dysfunction, or is it the emergency department, or is it eating disorders, right, if you're a child psychiatrist? So this is going to be, ED refers to emotional dysregulation. We're going to think a little bit about the pathophysiology, look at its impact on functioning, and think about the links between ED and psychiatric comorbidities, and finally think about treatment. So I'm going to try and do that in 20 minutes. This is a talk based on an article that a group of us are submitting for publication, so I really have to share this presentation's part, thinking by colleagues like Joe Blader, Betsy Bush, Ann Childress, Steve Ferrone, Jeff Newcorn. So I'm hoping I can represent what we're saying in this article. So first of all, why is it important? Well, clinicians know this is clearly important because lots of our patients can't handle their emotions and its impacts on development, and it's a large focus of our clinical interventions. From the nosologic side, there's a lot of confusion, controversy, etc. Is emotional dysregulation associated with ADHD, or is it constitutive of ADHD? And of course, the boundaries between difficulties with handling emotions and mood disorders are also fuzzy and overlapping, and so we think there need to be better tools, which is actually going to be my take-home message at the end of this talk. And finally, from the standpoint of the science, everybody's interested, as you've heard all through this meeting, and why ADHD has become such an important disorder for neuroscience, is that this is where we're looking at how do humans regulate themselves? How much can we control the ways we feel, act, and think? And that's why I think ADHD is the place where a lot of the action is going, and of course the shift to thinking more about circuits. So in terms of the prevalence, kids with ADHD, between 30 to 40% of them have a variety of real difficulties based simply on their difficulties with handling their emotions. These range from rage outbursts and irritability and overreactivity, low frustration tolerance, or susceptibility to anger. And you can see I've just quoted a few of the most recent studies, but this goes back decades to the earliest descriptions of ADHD, so it's not new. But what's really important is to realize that all along we've diagnosed ADHD and not really included any of those problems in the diagnosis. And when you look at adults, it's even more important. 50% or more have some form of emotional dysregulation, even without frank mood disorder. Now, what about the conceptualization? You know, we're using lots of terms. Everybody's got their favorite way to describe this. Is it emotional lability? Is it emotional reactivity? And are these the same or not? How about over-emotionality, affective reactivity? We've heard about newer terms suggested, emotional impulsivity and deficient emotional self-regulation. So we're going to just use the term ED because we just think it's the simplest way to capture most of these terms, and we think it's most relevant to our work in the clinical arena. So there are two major dimensions then of emotional dysregulation. One has to do with problems of the generating of the emotions themselves, and we see this expressed in a variety of ways. So not all of these are the same, but when there's a problem with generating emotion, you might have an insufficient ability to enjoy, sort of a low hedonic tone or anhedonia. You might have too much alarm, then you're anxious. You might have excessive generated sadness or euphoria. Again, at the extremes, this can become something like bipolar disorder or depression. And finally, this excessive frustration to even mildly noxious stimuli. So that's the generating side. And then the regulating side is overall a notion that it's hard to exert control over these emotions, and sometimes the emotional reactions are exaggerated, and then they lead to sequelae. So a nice way to summarize this is, and again, this is a simplification and really meant to just get the discussion going, because you're going to hear some elegant presentations on some of the neuroimaging of emotional dysregulation. But if you think about it from the top down, difficulties with emotion, with self-regulation, is sort of there may be then evidence that ADHD serves as an accelerant because you can't inhibit emotions. Okay, so the normal brain might be able to handle a bigger load, but with deficient emotional self-regulation, you can't even handle a normal emotional response all that well. Or, as I mentioned earlier, it could also be that the emotion generators are turned up too high, and then the question becomes, to what extent do people with ADHD experience this a lot of the time? You know, just too much emotional energy. Now, we looked over the literature and found that to try to measure this is daunting. We found 18 instruments out there. There is no standardized tool. Most of the scales focus on emotion regulation, although some also look at reactivity, lability, and expression. 8 of the scales are addressed for children, 2 for adults, and 8 were for both. Most of them are self-report. 13 of these instruments have been used in clinical trials, but none has been validated as a patient-reported outcome in these trials. So we know it's there, but it isn't being utilized as in clinical trials on a regular basis. 11 have norms, but most of these were developed not for people with ADHD, but rather for people with a variety of mood disorders. So the exceptions are those developed by Barkley and by Brown and by Connors, and of course the Wender-Reimer group, which I think we should owe a shout out to the Utah folks, because way back in the 70s they said, you know, temper outbursts, that's part of ADHD, and you know, not being easily annoyed and whatever. So here's, I'm not going to go through each of these, but this is just to give you a snapshot. The ones that are highlighted are those scales that were developed in ADHD, but you can see affective lability, affective reactivity. The brief has a dimension on emotion control, which some researchers are using. There's the Brown and the Connors, and I actually highlighted the shorter version of the Connors and the Wender-Reimer. So 18 different scales. What do we do about them? Notice that not all of them have been used in trials, not all of them have norms, and some are costly and some are free. Okay? Now, getting to this circuits question, we've been hearing a lot and for years, and this conference also signaled the coming of age of the notion of these CSTC, these corticostriatothalamic cortical loops, and in the basal ganglia. And the one that we're particularly interested in this discussion is the limbic loop, which receives inputs from the temporal cortex and the hippocampal formation. And then there are frontal inputs and thalamic projections. And you're going to hear more about this later. But the anterior cingulate and the orbitofrontal cortex clearly have an important role in both processing the information and figuring out what you're going to do with it. But a nice way to distinguish among these different forms, if you will, or profiles of emotional dysregulation, and Joe Blader kind of gave us this notion of thinking through a time course. You have a negative or intense emotion elicited. It doesn't have to be negative, but any emotion gets elicited. What happens over time to the peak levels of that emotion, and then how long does it take to go back to baseline? So in this conceptualization, where someone has typical development, there's an activating event that gets you sort of, starts to have emotions generated, and there's the subjective state of those emotions and the behavioral expression, that's in blue. And then you can see that they change in tandem, they reach a peak, and then it sort of dials back down and kind of gets back to baseline. This would be the more typical person's profile. Oh, I got happy, and then I come back. Or I got upset, and I come back. And the behavior, the expression, behaviorally and the emotional subjective are kind of lined up together. With ADHD, there may be higher degree of impulsive and emotional signaling, impulsivity, and also poorer self-modulation. So you'll see this sort of weak self-modulation with a high generation of emotions might be the profile in ADHD. And so it takes, first of all, they're more out of sync. It rises more quickly, they're out of sync, and they don't come back to baseline all that well. There's a longer recovery time. Now, with the patients who might be presenting more with mood and anxiety primarily, not with ADHD, the profile might look like a higher baseline emotional intensity to start with, a slower, and it's still in sync, but a longer and prolonged peak of emotion generation, and a slow kind of recovery, in part maybe because of counterproductive thoughts and ruminating over the negative and avoiding all of these things that patients with anxiety or depression do that make it harder for them to recover from that emotional dysregulated state. And finally, a fourth profile might be what we could call the frontally competent, or the self-modulatorily effective, but high rates of expression, short rise times, but people can sort of bounce up, but they can bounce back down, okay? And up doesn't mean necessarily good, it just means emotionally stimulated. So that's a way of disaggregating the phenomenology of these different profiles of emotional dysregulation. Again, this is all for conversation later. Now, the other important set of mechanisms which we've alluded to also in our work here is this notion of negative emotionality as an underlying childhood temperamental trait. And if you look at studies of happiness, what goes into happiness, a good portion of it has to do with your temperamental orientation. And there are children who may be negative emotionally just from the beginning, and they tend to be, and so if they have that plus ADHD, then you see this greater proneness to anger and easy frustration and low adaptability, and then they don't develop their executive control processes as effectively. Now, one possible hypothesis, and again, none of these are mutually exclusive, is this idea of a reward deficient state or reward deficiency syndrome. And this is where the ventral striatum plays a big role, because it may lead to sort of a drive for compensatory stimulation, looking for feeling better, needing that, and a greater sensitivity to when reward is removed, so that they become really easily annoyed because they need that stimulation. If it's not, that positive isn't there, boom, it feels like you're taking this away. It's sort of like trying to get a kid who's playing a video game to stop, right? Or any of us, if you turn off that TV right as the Eagles are about to win, I would get really mad because at that moment, I need that, and you took it away. But imagine this happening not around big events, but little events all throughout the day where you're getting constantly negative because your ventral striatum is underpowered, and that may explain why stimulants tend to get rid of this, because you don't need as much of that constant reward to make you feel okay. Of course, it also may explain why stimulants can be misused, and that's a big important concern of all of ours. Finally, the clinical implication of this is that high-intensity, unexpected stimuli induce these highly salient rewards and less sensitivity to low stimulating rewards. So they need higher and higher rewards to stay engaged, and the absence of this is experienced as aversive. And we think that's why they get very reactive with even minor provocations. How about the impact then of emotional dysregulation specifically in ADHD individuals? And this I'm going to just quickly, Dr. Biederman's work, Dr. Barkley's work, all of the longitudinal studies, we see this, that first of all, it is more prevalent in the combined type, more closely associated with the severity of ADHD as well as linked to ODD, and it predicts suspensions and expulsions and much, much more dysfunction in daily life. I like this cartoon. I couldn't help myself. My lack of serotonin made me do it. This is the kid using a brain description of his behavior. But that's what we see all the time, just. This also predicts less likelihood of remission. In other words, persistence of ADHD may also be tagged by this emotional dysregulation, and it does not get better over time. And that's the other important take-home message here, is that this has severe impairments throughout life and leads to the problems with employment and not holding jobs and not doing as well in jobs and getting fired and being bored and not graduating and getting into all the kinds of problems. It isn't strictly impulsivity. It is impulsivity and this dysregulation of emotions that seems to persist and cause problems. And just among many, many possible data sets, you can see the Milwaukee study here summarized that the persistent ADHD have loads of problems with being impatient, easy, frustrated, all the things that the Wender, Utah group saw, and that the non-persistent ADHD still have some degree of difficulty, less than the controls, and that it's really a persisting problem. Okay, so in terms of then moving into the comorbidity issue that Andy was mentioning, so then Of course, emotional dysregulation is part of a host of other disorders, and no matter what you think of this list, these are all taken from, we have questions about how these are the boundaries, but ODD, major depression, bipolar, the temper tantrum, mood dysregulation, conduct, all of these disorders have some facet in them of emotional dysregulation. So the question becomes, what clinical features of emotional dysregulation can help us distinguish among these disorders? And so again, our paper attempts to delineate a couple of these dimensions. So with respect to irritability, obviously, for example, irritability might be very chronic in ADHD, but with bipolar disorder, it might be episodic, and same with ADHD, with anxiety. The inappropriately positive emotions, you can see where those lie. Persistent anger throughout most of the day, more so with the intermittent explosive. And you can see then we're attempting here, although we can't say we have the tool to do this yet, would be nice to say with this profile, what tends to be, what do we think we're dealing with here, at least in its earliest stages, before it becomes full-blown disease state. Now to turn in the 2 minutes I have left to treatment, and the good news is that we know quite a bit about stimulant treatment seems to help lots and lots of facets of emotional dysregulation, although I'm not going to have time to go through each of these studies, but they're nicely powered studies, and it's both children and in adults. You can see that stimulants help with the emotion response during the time that they've been in the study. Atomoxetine, there's a few important papers, one that looked at a meta-analysis of methylphenidate and atomoxetine that showed a moderate effect. In the pediatric studies, small positive effects. In the adults, also 2 RCTs that showed improvements. And then Len's work looking at atomoxetine in young adults was also non-significant, but using just one aspect of the brief. But there was a tendency towards improvement. And then Phil's work, Phil Asherson's work looking at 3 studies found, there was improvement in emotional control on the brief A. So atomoxetine may be helpful. There are some behavioral interventions as well, looking at the Incredible Years program, also at parent behavior management in children. These seem to be helpful, in part probably because parents are less emotionally reactive, and therefore so might the kids be. And finally, a couple of new studies coming out, especially using DBT-type skills in adults with ADHD. So just to conclude, ED is important. It should be considered an associated feature like learning disabilities or executive functioning deficits. It's linked to higher impairment. It's only partially responsive, but there's some signal there. We've got dopamine involved in limbic regions, and given this, we think that it should be part of the diagnostic criteria. Of course, that's going to take a long time to change. So for the time being, we need to figure out how to measure it better, and I think that's why we need to try our best to come up with new tools, and also to make sure that in positing what pediatricians and primary care folks need to do is they certainly need to look at this dimension of ADHD, because maybe the hyperactivity isn't so prominent, but if the moodiness is, that's something we need to pay attention to. And with that, I will shut up. Thank you.
Tony, thanks so much. Thanks so much for thanks. Okay, great. We'll start it.
So I'm Jonathan Posner. I'm really happy to be here. Thank you, everyone who's still here, the last symposium of the conference. So I'm going to be talking about mesolimbic circuitry in ADHD, and I'm focusing on that because of all the different neural systems that have been implicated in ADHD, the mesolimbic or mesocortical limbic system is the one that's most tightly associated with affective symptoms. Disclosures, I've received funding from Shire Pharmaceuticals and Avi Genomics. So as I mentioned, I'm gonna sort of delve into mesolimbic circuitry, review the recent MRI studies that have looked at this system in ADHD. Then I'll talk about some conceptual models linking these brain abnormalities with the clinical phenotype of ADHD. And then I really want to get into some implications and some of the work that my lab is starting to do around prevention, focusing on, again, on this, in this circuit. So as an overview, there's lots of different brain circuits that have been implicated in ADHD, but I've listed 3 of the main players here. So on the top in the green, frontoparietal circuits, which are implicated in alerting responses, orienting attention, allocating attentional resources. Dorsal frontal striatal circuits, which are implicated in response suppression, inhibitory control, and executive functions. And then the circuit that I'll be focusing on, mesocortical limbic or mesolimbic circuits, related to motivation, reward processing, and also to frustration and potentially aggression. So to delve a little bit deeper into that system, we know that the mesolimbic system emerges from dopaminergic projections from the ventral tegmental area, which is in the brainstem, projecting up to the nucleus accumbens, as well as the orbital frontal cortex and the amygdala. And so those are the primary substrates that I'll be focusing on. So one of the first MRI studies looking at the amygdala in ADHD was by Plessin in 2006. They looked at about 50 children with ADHD compared to controls. They found no overall volumetric difference in the amygdala, but they did find a difference in the surface area. So when they measured the surface of the amygdala, particularly in the basolateral surface, they found reductions there in ADHD that correlated with diagnostic symptoms, so hyperactive and inattentive symptoms. A subsequent study looking at this in adults by Fraudel in 2010, here they found a reduction in actual volumes of the amygdala, and they compared those to healthy controls as well as individuals with major depression. They found reductions in the right amygdala that correlated with hyperactive symptoms. There have been some mixed findings. There was a study in 2008 where there was no difference found. However, there were potentially some methodological limitations. They were using a 1.5 Tesla magnet, which is a bit weaker. Looking at the ventral striatum, so the ventral striatum is a sort of umbrella region that encompasses the nucleus accumbens. The terms are often used interchangeably. The ventral striatum technically is a little bit larger than the nucleus accumbens, but again, the terms are often used interchangeably. So a study in 2009 by Carmona compared about 40 kids with ADHD versus controlled. They found reduced volumes of the ventral striatum bilaterally, left and right side, and that was, again, correlated with ADHD symptoms. My lab conducted a study in 2015, also looking at the nucleus accumbens. Similar to the prior report, we found a reduction in accumbens volumes, but only on the right-hand side. So all the studies that I've presented so far are using sort of very, very small samples. If people heard about the Enigma study today, it really was a leap forward. The sample sizes went up by an order of magnitude. So 1,700 ADHD cases, 1,500 healthy controls, 23 sites internationally, across a wide age range. But the nice thing to see was that those findings were replicated. So decreases in the volumes of both the accumbens and the amygdala were reported in the Enigma study. And as was pointed out earlier, the amygdala showed the largest effect size, and also the accumbens showed the second largest effect size. So certainly the circuit seems to be a major player in ADHD. It was noted earlier, but I just want to reiterate the point that more dorsal structures within the basal ganglia typically get most of the focus and attention of MRI research in ADHD, but at least based on the Enigma study, the effects are larger in these more ventral structures, mesolimbic structures. So now I'm going to switch and talk a little bit about connectivity within this circuit. So my lab did a study looking at structural connectivity from diffusion MRI based on tractography. So basically measuring the white matter tracks that connect the nucleus accumbens to the orbital frontal cortex. We looked at that in children with ADHD, and we found on the left side there was reduced connectivity within that system, so going from the accumbens to the orbital frontal cortex. We then used two different machine learning algorithms, and based on those algorithms, we found that the organization of that circuit, so the connectivity of that mesolimbic system, predicted about 25% of the variance in aggression or irritability in these children. Aggression based on the CBCL measurement, which is a pretty powerful finding, that 25% of the variance was predicted by one single circuit. We also had similar findings using functional connectivity. So as opposed to, instead of measuring the actual white matter tracks that connect two brain regions, it's measuring the synchrony across those brain regions. And similar to our structural connectivity findings, we again found reduced connectivity between the accumbens and the orbital frontal cortex in children with ADHD, and in this case it was correlated with emotional lability. That was from the Connors assessment. I want to digress slightly and just talk a little bit about a transdiagnostic issue in the age of RDoC. Transdiagnostic considerations are certainly important. And when people look at brain imaging markers from an RDoC perspective, typically they look at disorders that are quite similar or tend to be comorbid, which is helpful. But I also think another helpful perspective is to look at disorders that, at least conceptually, could be considered almost like the polar opposite. And that's how I think certain aspects of anorexia would fall into that category. So ADHD is sort of the paradigmatic disorder of poor impulse control versus anorexia, the paradigmatic disorder of superior impulse control, the ability to restrain urges that are so biologically primitive as hunger. So we looked at the same mesolimbic circuit using diffusion imaging in young adult women with anorexia. We scanned them during the acute phase of the illness when they were quite underweight, and then we scanned them again following weight restoration when their weight had been restored to 90% of ideal body weight. And you'll notice the images look quite similar to the structural images that I showed you in ADHD. However, the big important difference is that the findings are actually the opposite. In our patients with anorexia, we see hyperconnectivity within this circuit. And we saw that during the acute underweight phase of the illness, and then we saw it again post-weight restoration. And one somewhat, sorry, I want to use the pointer for a second. One finding that I want to just highlight is in the blue there are the healthy control participants at time 1 and time 2. It seems like a trivial finding that's easy to overlook, but in MRI research, it's very rare to find something that's quite that stable and reproducible. And in our healthy controls, there was very little change in their structural connectivity measurement. One of the questions that came up earlier today in the context of the Enigma study was, how do you make use of smaller sample sizes with MRI data? And I think one approach is to be able to, particularly with measurements that should be trait-like, to be able to actually show the stability of those measurements, I think is really important and unfortunately seldom done. It's also not just a conceptual link between anorexia and ADHD. There actually is an empirical link to bolster the argument that conceptually you can think of them as almost opposites. And that comes from the literature on delayed gratification, from the delayed discounting task, which measures how able are people to put off a gratification, to say no to an immediate small reward in favor of a larger delayed reward. And so these data come from a colleague of mine, Joanna Steinglass, who's also at Columbia. She gave the delayed discounting task to patients with anorexia And what's quite interesting about her findings is that the patients with anorexia actually have a superior ability, superior relative to unaffected peers, to be able to delay gratification, to say no to the immediate reward. And that was most robust in patients with anorexia, the restricting subtype, as opposed to the binge purge subtype. And another note about this is that it's quite rare in psychiatric disorders to see a population that's actually superior on a neuropsychological test. Almost invariably, they do poorer, and that broken brains are broken. So this is quite an interesting finding. And in ADHD, we see the opposite effect. So on the delayed discounting task, kids with ADHD tend to choose the smaller immediate reward. So back to ADHD for talking about task-related fMRI studies. Again, on this mesolimbic circuit, this was a meta-analysis released in 2014 looking at the monetary incentive delay task, which looks at ventral striatal activation in response to an anticipated reward. And in this meta-analysis, essentially what they found was that 7 studies had looked at this in ADHD. 6 of the 7 studies found hypoactivation in ADHD during the anticipatory phase of the monetary incentive task. Amygdala function has also been looked at. Several years ago now, my lab looked at this using a masked fear faces task, and we found ADHD children had hyperactivation of the left amygdala that seemed to be at least partially normalized with stimulant medication. More recently, we've done something a bit similar. We used an imaging modality called arterial spin labeling, which just looks at the perfusion of blood to different brain regions. So free of any task-related activity. We found that children before treatment with ADHD had hyperperfusion to the amygdala, and that treatment with amphetamines seemed to have a normalizing effect on that hyperperfusion. So to summarize some of the findings, I hope I've convinced you that there's pretty good data implicating the mesolimbic system in ADHD based on volumetric studies of the amygdala, nucleus accumbens, also based on structural and functional connectivity findings, particularly between the nucleus accumbens and the orbital frontal cortex, and then also based on functional activity, both task and perfusion. So what does this all mean? How do we actually relate these brain imaging findings to the clinical phenotype? And here I move a bit away from the data and a bit more into a speculative area because the relationship between these models and the MRI findings is still speculative. So one of the really helpful models was proposed by Edmund Shanuga-Bark, talking about delay aversion. So this idea that children with, we all dislike waiting for things, but for children with ADHD, that experience is particularly aversive. And that's potentially encoded both through the nucleus accumbens and the amygdala. Danny Weinberger, in a different population, not ADHD, proposed a model of affective salience detection, that the orbital frontal cortex and the amygdala are specialized in detecting affective salience, so detecting emotionally important stimuli. And that potentially relates to ADHD in that you have sort of this hyper-detective response system leading to emotional impulsivity and potentially distractibility. Another more recent model proposed by Michael Frank relates to decision-making and prediction error, suggesting that there's reduced prediction error in ADHD. So the ability to encode the relationship between a stimulus and a reward is weakened in ADHD, leading to impulsive reactions to obtain the most immediate, most concrete reward, as opposed to a more delayed or abstract reward. And then the last potential model is one that we spoke about in our findings on structural connectivity in the orbital frontal cortex. that when the expectations for reward, when there's a mismatch with reality, you have these reactions. I'm going to plow through a little bit because I want to show you some of the future directions that we're interested in. So we know ADHD is a highly heritable disorder, but we also know that a good number of cases are attributable to environmental causes. And even if those cases are relatively less common relative to the heritable cases or genetic cases, it's such a common disorder that still quite a number of kids. And we think that this mesolimbic system is probably a good target to go after for prevention. And we based that on the literature emerging from fetal programming and in utero exposures. So just very quickly to go over some of that, there's now been a lot of epidemiologic studies looking at the intrauterine environment and how that can set a child up for developing ADHD. There are pretty strong associations between prenatal maternal anxiety, depression, or general distress, and the offspring developing ADHD. There are associations between maternal obesity and the offspring having increased risk for ADHD. That's now been replicated across 7 cohorts of 400,000 children. There are also studies suggesting a relationship between in utero exposure to various toxins, particularly flame retardants, and subsequent development of ADHD. These are all observational epidemiologic studies. It's important to work on and understand the mechanisms to see if these are actually causally related or if there are other explanations like shared familial risk. So what's emerged from the animal literature delving into this is that there's potentially a common pathway through increased intrauterine inflammation, of which dopaminergic neurons, particularly mesolimbic system, is quite sensitive to. So the hypothesis would be that these various intrauterine exposures leads to increased intrauterine inflammation, altering the trajectory of the mesolimbic system and increasing rates of ADHD in the offspring. So the studies that my lab is now working on is really trying to test those hypotheses. So we're enrolling women when they are pregnant, conducting a prenatal assessment of mood, stress, body mass index, inflammatory markers, physical activity, a few other measurements. We then obtain MRI scans on their offspring at 4 weeks of age. Non-sedated babies have multimodal imaging done, and then conducting assessments of the toddlers at age 2. And our goal really in doing this is to identify targetable mediators. So if it really is the case that these inflammatory markers are mediating between intrauteral exposures and offspring outcomes, that would be incredibly important information to have and potentially point to new interventions. And I will quickly just show you some initial data that we have where we looked at the effects of prenatal maternal depression. We looked at this in 20 infants who were exposed, so whose mothers were depressed during pregnancy, versus 44 unexposed. We obtained MRI scans at anywhere between 4 to 6 weeks of age, and we looked at amygdala-seated connectivity in these offspring. And essentially what you'll see is that the children who were exposed showed atypical connectivity from the amygdala to the prefrontal cortex, but also, interestingly, to several other regions like the posterior cingulate and the parietal lobes that have been heavily implicated in ADHD. So we still need behavioral outcomes on these kids, but it's a promising start. And so with that, I just want to thank the people in my lab, Juk Cha, who's the individual who did most of the structural connectivity work, and Claudia Lugo, who's spearheading the infant studies. So with that, I'll stop.
Jonathan, and again, I promise we will end at 4:30. It occurs to me, as I'm listening to all of the presentations, that usually we don't get complaints from parents that the kids have emotional dysregulation because they're overly calm, serene, resilient, cheerful, optimistic, pleasant, friendly, patient. So the emotional lability is negatively valenced because that's really what causes the problems. So I wonder if the panel has some thoughts about why it really is so much of a problem in the negative valence, and it's not just emotion in general.
I think it's self-evident, no? It's as if you are difficult, you don't bring joy neither to teachers, parents, friends. You are a pain in the tushy. So it's a very serious matter. And I am not so, I would like to generically raise the issue that I believe the management of emotional difficulties, the one that I described in the self-regulation, is an unmet need in ADHD. So I would like not to be so excited that we have the perfect treatments, and it's a serious problem that is not universal, but those 50% that have it, they have much more impairment, and the treatments that we deploy more commonly than not, at least in my hand, I am a very active clinician, they do not work well for this problem. So I would caution against overexcitement that we actually have unbelievable tools. And the idea that Depakote is a treatment for this is unbelievable too. I think Depakote has a very unclear effect in bipolar illness, but I certainly will not use it in a toxic drug like Depakote for the management of emotionality in children with ADHD.
I wanted to respond also, though, to, I mean, there were great comments all of you have made, but in terms of aggregating, there's a genetic predisposition to being emotionally labile or reactive, as we've been describing. But then that learning paradigm that you were talking about, and this is what I think Russ Barkley has talked about. So what's genetic is that the kid gets pissed off really quickly or frustrated easily. But the learned part, and this is where I think early intervention is also important, is the context then has to be that the parent's response has to be not to get angry right back, or to escalate and make things worse. So a lot of our interventions early on have to do with that dyadic relationship, and partly getting the kid on a medication, which for years and years has been shown. Even earliest, I remember reading a paper in the early 90s that showed if all you had to do through an observational study, and I believe it was a Barkley paper, that if you started giving the child stimulant, the negative interactions between parent and child went back to normal when they were being observed in the waiting room, that there was less of this controlling and negative, managing style, and a much more typical. So I would say that the component that's learned and that we do as both clinicians and researchers need to pay attention to, and this is where I think the research needs to go further, is if the parent has ADHD, you see, and they're not prepared for this, then I think we've got a real setup, and that's where the environ type plays a role, because a parent who's calmer might have a better chance at both helping the child when they're upset and also not being as the residual effect, if you will, later on, coming at the child with a negative attitude, which then becomes reinforcing.
Dr. Veronica.
Sorry. Yeah, I wanted to comment on the question about positive versus negative valence. Tony talked about, and you too, Joe, talked about, Russ Barkley's idea of disordered emotional self-regulation, which implies an inability to self-regulate emotions regardless of valence. We also know, I know from personal experience of my ADHD child that Joe so kindly treated for me, he could be irritable and a problem, and I really didn't like that, but he was kind of goofy, silly, and clowning around. We had a lot of fun. But in a way, it's the same kind of emotional dysregulation. And I'll throw in one other comment that I'd like you guys to comment on, is that I wonder, we all know about this, this complaint that's not well documented in the adverse events literature of stimulants, that patients complain about their kind of personality being subdued.
Correct.
In a way, I wonder.
It's a different problem.
But let me just ask you, before you comment, Joe, I'm just wondering, is it the same effect we see, because we do see that stimulants help emotional regulation of negative emotions? Are they also dampening down the regulation of, are they also helping these kids in a way regulate their positive emotions where they're not as silly, goofy, clowning around, and therefore they're not as fun anymore? Just.
I would like to address that because we studied that in our preclinical work, and we found an association between methylphenidate and kappa opiate and the effects on opiate receptors that include kappa opiate receptors. And we also found in our animal model of ADHD that in the frontal cortex of the animal, there is an excess of kappa receptors. Kappa receptors are dysphorogenic. So this, the most common problem I encounter in clinical practice is the complaint about the medication making you feel different. You are not fun. It's not so much a goofy kind of, but not feeling right. That is not really captured in any of our databases of side effects, but is by far, in my experience in practicing psychiatry, the most common reason for people not to want to take it anymore because they cannot tolerate. I believe it's due to the effects of stimulants on kappa opiate receptors. It's different than getting irritable. It's just not feeling right and feeling blunted.
Can I ask Jonathan, on the mesolimbic connectivity measures, do they correlate differently with ADHD versus measures of emotional ability versus maybe other measures of motivation or sensation seeking? Because it seems we're trying to get that one circuit to do a lot of work. And I just foresee some problems in sorting that out.
Yeah, I mean, you're right, the correlations that we saw within that circuit were different across different studies, which I think is what you're getting at. So we saw in one study, when we looked at the structural connectivity, we saw an association with aggression. On another study, we saw a correlation with emotional ability. I think there's some overlap in those measurements, certainly. But I also think it's not, I think that circuit is obviously complicated and probably underlies lots of different cognitive processes, all within the domain of reward processing. But what I was trying to get at in showing those different conceptual models is that multiple functions are probably engaged by that system, and trying to nail down which specific function has gone awry in ADHD, I think is a notable goal, but I think it's going to be very, very difficult. And I think it probably depends a lot on the specific individual, the developmental stage, and the environmental challenges at play. So my thought is that first and foremost, being able to reliably characterize the architecture of the circuit is going to be a more fruitful approach than nailing down the specific behavioral phenotype.
Hi, I'm Karen Barblow from McLean, Virginia. This is a really compelling topic, thank you. I'm wondering if anyone has looked at emotional lability as it overlays the construct of cognitive rigidity. I think clinically we see that the kids who are more emotionally labile are also the kids who have more cognitive rigidity. They go hand in hand, and I think the reason that that's an important question is because the treatment implications are vast. You know, the SSRIs showing efficacy with the cognitive rigidity and the stimulants showing, like, where does that all line up?
Tourette syndrome is the paradigm for that.
Why is that?
One paradigm for that is the Tourettic child who, on the one hand, is ADD, but also gets stuck a lot and gets rigid, and that there is an interesting combination of approaches that you need then to try to help both manage the impulsivity, but also not worsen the rigidity and the fixed kind of reaction, which then leads to a different kind of explosiveness, which is, and we call it obsessional defiant rather than oppositional defiant disorder, because they are obsessed with staying and doing something and they can't let go.
My experience is a little bit different. Cognitive inflexibility is the only neuropsychological variable that distinguishes high-functioning autism spectrum with ADHD. And I think it's similar to the discourse today that we use 20 terms to define a clinical problem. I think cognitive inflexibility means different things to different people. So if you ask in the context of autism, particularly high-functioning autism, this issue of cognitive rigidity is a frequent precipitant for difficulties in regulating emotion. You cannot go from activity A to activity. Turning off the TV is a very good reason to go ballistic, for example. So it's a different problem. So it's not instead of, and I would question the idea that SSRIs are good for cognitive inflexibility in autism, because it's one of another unmet need that is very difficult to crack. So I'm not sure how effective they are if you are defining cognitive inflexibility the way that I'm defining it. But the problem in these cases, and we see that, for example, in OCD as well, is not cognitive inflexibility, but the person is engaged in some kind of ritualistic behavior and try to stop it. Okay, so stop washing your hands, not always leading to a very successful outcome in the household.
Jairus?
Yeah, I think both things happen. It is very interesting. I think it's right that there is the inflexibility of the type, I can't let go of washing my hands, or what you heard about Tourette's. And we have published about this. We've published about OCD and temper outbursts in OCD. The interesting thing about that is that there's a lot of parental accommodation that goes into it, the social learning that we were talking about before, that makes it worse, so that parents give in and the problem becomes worse. The other issue, though, is that we have data, again, that we have published about autism and emotional dysregulation in autism. And of all the autism symptom domains that we looked at, rigidity was the most predictive. And that's a different form of rigidity than it's kind of more the autistic type rigidity. To my knowledge, there hasn't been a study so far that looks at the various conceptualizations of rigidity and the outcome of emotional ability. I would say that clinically, there are a number of ways of trying to tackle it, psychological ways that could help, and functional analysis of behavior can be very helpful in that regard, the typical ABC kind of approach to it, which if one has time to do that, I think can make a difference. Though again, there is no big evidence based on this. One would hope. I mean, there is. Yeah, it's an interesting question. It goes back to the comments that were made about possible side effects of stimulants. So there are some people who say that some of the inflexibility may become worse under stimulants. I think it's just part of the dysphoria that you heard about before. And I think the first person to describe this dysphoria formally was Judy Rappaport in one of her studies about this kind of methylphenidate-induced dysphoria. Yeah.
I'm David Oxer from the VA Boston system, and of course we treat adults, and a lot of adults with ADHD, but also we see a tremendous amount of PTSD, which is a cause of emotional lability that hasn't been particularly emphasized in the panel today. But when you see people in the VA that can't sleep, have nightmares every night practically, and are extremely irritable and overreactive to all kinds of things. You could say if you can identify the particular precipitants to their irritability, it's related to the trauma, and that might differentiate it from the emotional lability connected with ADHD. But that can be a very hard differentiation that requires subtle evaluation, and often they don't see a direct connection between what's making them irritable. So my question is, when you're faced with these very irritable people, and very often they have ADHD, and ADHD may have predisposed them to get the traumas that they got as well. So, I mean, as well as TBI, I saw from one of the posters. That can be one of the outcomes of ADHD, which further gives you irritability. So how do you differentiate this irritability, and would you treat, and what treatment approach would you take? Would you go after the ADHD first, or would you go after the PTSD, let's say with something like prazosin during the day, to help them be less overreactive? Your thoughts?
Well, I have many thoughts, but maybe my colleagues say, first there is an association between ADHD and PTSD and TBI. We presented TBI, PTSD was last year. I think that you treat what you, first the rule of thumb is you treat the more severe problem first. So differential diagnosis is important. Is this part of a depressive state, a bipolar state, or is just reactivity? I tried my best to talk about this issue of overreactive, and the overreactive type of reactivity is not so easy to treat. So that's part of my message. That is not something that we don't use a cannon to kill a mosquito, so we don't deploy the armamentarium of bipolar illness in the context of overreactivity. But if your patient suffers from a serious mood disorder, unipolar or bipolar, you can target that in the hope that that will decrease the irritability that is very common in both unipolar and bipolar mood disorders.
And let me echo that and add that we see these comorbidities of PTSD or hyper-startled, that startle reaction and the almost ready to pop, and someone has ADD as well. And again, not saying that I have an answer, but we then try to talk with patients if prazosin has been used or isn't working. Maybe we'd switch them to guanfacine or clonidine. I didn't talk about the guanfacine studies because even though they looked at oppositional defiant behavior, they haven't really come up with measures of how this affects that emotional reactivity or lability. So possibly going after ADD if that's more impairing, or we might start with stimulant and add guanfacine or vice versa. It's really hard to say generically, but I do think that other approaches are going to have to be researched as well.
I think it's a great question, and we've recently meta-analyzed the association between emotional lability and PTSD. Of course, it's substantial, it's very strong. I would say that one of the most efficacious treatments of PTSD is, of course, trauma-focused CBT.
Yeah, of course.
And it's very hard to do that unless someone can concentrate. So that I have found that I often start with treating the ADHD, at least to get to some level where people can kind of start doing the actual trauma work. So that's been my experience. Of course, yeah, there's no evidence base for that yet. Yeah.
Thank you.
Thank you. Thank you for the question.
And so in our last 7 minutes left, I think we have time for 2 last questions.
Well, actually, I have no comment at all. This is a straightforward question for Dr. Posner. If I followed your presentation, you have hypoconnectivity in the mesolimbic area, and yet you have hyperactivity. A, how do you conceptually understand that? And B, is there a comparative to a neutral state versus a high emotion state?
So I'll take the second question first, then I'll come back. In the study that I showed you of amygdala hyperactivity, there is a comparison. It's a mass face paradigm where you compare frightened faces to neutral faces, and it's hyper amygdala activation in the fear faces relative to the neutral faces. For the second question, it depends a little bit on the modality. So for functional connectivity, you can have hyperactivity in one region and have disconnectivity, because essentially what you're measuring is the synchronization of neural activity across 2 different neural regions. So if one is very active, that doesn't mean that the other one is equally hyperactive or hyperactive in the same time sequence. And that's how you can lead to disconnectivity.
Okay, great, thank you.
Yeah.
And the last question for the last session on the last day, reserved for Dr. Newcourt.
Can we thank Jeff Newcorn, all of us that are still here, for his erstwhile leadership? Nobody got up and said this, but this is the man. This is the rock star of this meeting.
Look, we're up over 100 people this year, and we're leaving here with a lot of questions, which means we have to come back.
Yeah.
And so this is a good session because it leaves us with questions. And so what is this thing, right? It's not really explained by hyperactivity. It's not really explained by attention deficit. You see it a lot in attention deficit disorder, but everybody that has attention deficit disorder doesn't have it. It's a real conundrum. I guess it's probably good enough to say that it's part of a broader self-regulatory deficit that characterizes ADHD. And when I start to think that way, I start to think that we've got the wrong name for the condition.
Yeah.
But maybe that's a subject for another meeting. The final comment I would make about this, and I'm not really asking a question, I'm making a couple of comments because I think about these things a lot, and I'd be happy to hear what you all think about it, is that the kids that I treat that have this are very, Joe said this, they're very hard to treat. Everybody knows this, they're very hard to treat. And I think one of the dilemmas you have when you're a researcher and a clinician is you get caught about what to believe. And I think if you're thoughtful, my view of it is you shouldn't believe anything too much. You shouldn't believe your research too much. You shouldn't believe your clinical intuitions too much unless you have data. And you need something that pulls that stuff together. These kids, I think, are very hard to treat in monotherapy.
They are.
And even though the effect sizes for stimulants may be very good, the problem is people are complaining about their behavior all day long. And unless you're going to give them an IV drip of stimulants, it's going to be awfully hard to have that be an effective monotherapy. So regardless of how the molecule works, the temporal characteristics of the treatment might take on even greater importance than, let's say, the utility of the molecule. So, I feel like these kids almost always need something that works all the time, and they may need stimulants too. And, well, I'd be happy to hear your thoughts on all those things.
Gentlemen, we have 3 minutes left.
Well, I would like to say that the bidirectionality of being informed of our questions by what you see is what at least drives my work. So when I see this problem, and I start the bipolar illness, I did not have an epiphany in kindergarten that I will describe, but came by looking at my own data, that I have a problem that was never reported before. So this issue, because I agree with you, it's a serious problem, I try to define it. So I go back and I look at any way that I can understand it a little bit better. And the first thing that I try to do in thinking about this problem that I try to share with you is to try to differentiate the reactivity kind of problem from a mood disorder, because the treatment varies. I know how to treat mood disorders very well, but this is different. So the issue of the differential diagnosis and using terms, our president does not believe that words matter, but words matter. When you call something something, you need to know how are you defining that something, and then you can target it. If you put a broad spectrum and everything goes, so irritability, aggression, they're not the same phenomenon. Okay.
Jairus, you get the last word.
I would say that they are often very hard to treat. I would agree with that, children who present with emotional ability. Of course, we are caught in the dilemma as clinicians because our primary goal is to do no harm. So I would say that we must be cautious with it. And I think that it calls for a study, whether a combination therapy is important or not. Similar questions were asked in schizophrenia, whether 2 rather than 1 antipsychotic or 3 rather than 2 were more important. And the studies came out, and the polypharmacy wasn't better. So I think it is an empirical question, but it is a very well-posed problem to which I resonate also clinically with you very much.
So I want to salute that question because I think it leads me to be humble as well. I believe that this, at least my work in the last 5 years, has really been influenced with this notion of a reward deficiency state, and that people really need to feel reward, and when they don't, they seek it, and that looking and understanding our patients at whatever stage they are in the life cycle, that a lot of what they're having trouble with in this global sense of self-regulation is it's the solutions they find to those reward deficiency states that might get them into trouble. So they may overuse digital media, they may get into cigarette smoking, all the problems we heard Tim Willens talking about and others the other night. And so it is, I think, the biggest challenge for us as a field to really define ADD not just as hyperactivity, impulsivity, and inattention, but also this dimension that is really important to the person themselves. Because when you ask kids, it's not just whether the medication makes you feel good or not. It's what makes you feel good and what makes you feel upset. And when you get upset, what you do, well, some of them avoid, and they become super avoidant because they're avoiding dysphoric states and won't do their homework because their homework is hard, not because they're lazy. And they'll seek and they'll externalize when they're frustrated and blame everybody else. Say the teacher gave me too much work, my parents made me do my homework and I wasn't ready, et cetera, et cetera. So I think we should keep talking about this.
Well, join me in thanking the panel. Thank you all for staying till the end.
Good job. Thank you. Thank you. That was lovely, really, really great to have. Well, I will talk with you on some. Oh, yeah.